Before we go into arterial blood gas, let us look at gaseous exchange so we can understand arterial blood gas. The primary function of the respiratory system is to take in oxygen and eliminate carbon dioxide. Inhaled oxygen enters the lungs and reaches the alveoli. The layers of cells lining the alveoli and the surrounding capillaries are each only 1 cell thick and are in very close contact with each other. This barrier between air and blood averages about 1 micron in thickness. Oxygen passes quickly through this air-blood barrier into the blood in the capillaries. Similarly, carbon dioxide passes from the blood into the alveoli and is then exhaled. Oxygenated blood travels from the lungs through the pulmonary veins and into the left side of the heart, which pumps the blood to the rest of the body. Oxygen-deficient, carbon dioxide-rich blood returns to the right side of the heart through 2 large veins, the superior vena cava and the inferior vena cava. Then the blood is pumped through the pulmonary artery to the lungs, where it picks up oxygen and releases carbon dioxide. To support the absorption of oxygen and release of carbon dioxide, about 5 to 8 liters of air per minute are brought in and out of the lungs, and about 0.3 of a liter of oxygen is transferred from the alveoli to the blood each minute, even when the person is at rest. At the same time, a similar volume of carbon dioxide moves from the blood to the alveoli and is exhaled. The rate at which oxygen is used by the body is one measure of the rate of energy expended by the body. Breathing in and out is accomplished by respiratory muscles. 3 processes are essential for the transfer of oxygen from the outside air to the blood flowing through the lungs: ventilation, diffusion, and perfusion. Ventilation is the process by which air moves in and out of the lungs. Diffusion is the spontaneous movement of gases, without the use of any energy or effort by the body, between the alveoli and the capillaries in the lungs. Perfusion is the process by which the cardiovascular system pumps blood throughout the lungs. The body's circulation is an essential link between the atmosphere, which contains oxygen, and the cells of the body, which consume oxygen. For example, the delivery of oxygen to the muscle cells throughout the body depends not only on the lungs but also on the ability of the blood to carry oxygen and on the ability of the circulation to transport blood to muscle. In addition, a small fraction of the blood pumped from the heart enters the bronchial arteries and nourishes the airways. What is arterial blood gas? An arterial blood gas, ABG, test is a blood test that measures the acidity, or pH, and the levels of oxygen, O2, and carbon dioxide, CO2, from an artery. The test is used to check the function of the patient's lungs and how well they are able to move oxygen into the blood and remove carbon dioxide. An ABG is one of the most commonly used tests to measure oxygenation and blood acid levels. 2. Important measures of a patient's clinical status, and correct interpretation can lead to quicker and more accurate changes in the plan of care. It's commonly performed in the ICU and ER setting. However, ABGs can be drawn on any patient on any floor, depending on their diagnosis. Arterial blood gases can be confusing to understand at first. However, it's a crucial skill for nurses, physicians, respiratory therapists, and nursing students to learn how to draw an ABG. Arterial blood gas requires the collection of blood. Blood can be drawn via an arterial stick from the wrist, groin, or above the elbow. The radial artery on the wrist is most used to obtain the sample. However, the femoral artery and brachial artery can be used if necessary. If the patient already has a pre-existing arterial line, this can be used to obtain the sample. What is measured in an ABG? There are 6 key components to an ABG. They include 1. pH. This measures the balance of acids and bases in your blood. 2. Partial pressure of oxygen, PaO2. This measures the pressure of oxygen dissolved in your blood. 3. Partial pressure of carbon dioxide, PaCO2. This measures the amount of carbon dioxide in your blood and how well carbon dioxide can move out of your body. 4. Bicarbonate. HCO3. This is calculated using the measured values of pH and PaCO2 to determine the amount of the basic compound made from carbon dioxide, CO2. 5. Oxygen saturation, O2 sat. This measures how much hemoglobin in your blood is carrying oxygen. 6. Oxygen content, O2 CT. This measures the amount of oxygen in your blood. ABG normal values. The aforementioned components all have different normal values and represent different aspects of the blood gas. According to the National Institute of Health, typical normal values are pH, 7.35 to 7.45. Partial pressure of oxygen, PaO2, 75 to 100 mm of mercury. Partial pressure of carbon dioxide, PaCO2, 35 to 45 mm of mercury. Bicarbonate, HCO3, 22 to 26 milliequivalents per liter. Oxygen saturation, O2 sat, 94 to 100%. How to interpret ABG results? The first value you should look at is the pH to determine if the patient is in the normal range, above, or below. If a patient's pH is greater than 7.45, the patient is in alkalosis. If the pH is lesser than 7.35, then the patient has acidosis. Remember, the lower the pH number, the higher the acid level in the body. And even with a normal pH level, acidosis or alkalosis may still be present, as the body can compensate to balance the pH. Next, examine the PaCO2. This will determine if the changes in the blood gas are due to the respiratory system or metabolically driven. In combination with the HCO3, you will be able to fully comprehend the blood gas. Respiratory opposite. In respiratory disorders, the pH and CO2 arrows move in opposite directions. Metabolic equal. In metabolic disorders, the pH and CO2 arrows will move in the same direction. What is compensation? Compensation is the body's attempt to bring the acid-base imbalance back to normal. When compensating an acid-base disturbance, the system not responsible for the imbalance attempts to bring the blood pH back to normal. Compensation, however, is not correction. Unless the underlying condition is rectified, the imbalance is not corrected. Compensation examples. Metabolic acidosis. In metabolic acidosis, the respiratory system attempts to compensate by increasing the rate and depth of respirations through hyperventilation. When the pH drops below normal, the peripheral chemoreceptors stimulate the respiratory system in the brainstem. This increases the rate and depth of respirations in an attempt to blow off CO2 and therefore to lower the carbonic acid blood level. By lowering the carbonic acid level, there is less acid in the blood for the bicarbonate to buffer, helping to raise the bicarbonate levels. The arterial blood gases in a patient with a compensated metabolic acidosis show a slightly low or normal pH level of 7.35 to 7.40, a decreased HCO3, initial problem, level less than 23 milliequivalents per liter, and a decreased PCO2, compensatory response, less than 35 mm of mercury. Respiratory acidosis. Once you have identified respiratory acidosis, you need to determine if the metabolic system is compensating or not. The metabolic system can be represented by bicarbonate, HCO3, so we can look to HCO3 to determine how much, if at all, the metabolic system is compensating. If HCO3 is in the normal range, 22 to 26 milliequivalents per liter, the metabolic system is not trying to compensate for the acidosis. If HO3 level is basic, over 26 milliequivalents per liter, it means the metabolic system is trying to compensate for respiratory acidosis. Metabolic alkalosis. Metabolic alkalosis is defined as elevation of the body's pH above 7.45. Metabolic alkalosis involves a primary increase in serum bicarbonate, HCO3, concentration, due to a loss of H+ from the body or a gain in HCO3. As a compensatory mechanism, metabolic alkalosis leads to alveolar hypoventilation with a rise in arterial carbon dioxide tension, PaCO2, which diminishes the change in pH that would otherwise occur. Respiratory alkalosis. Compensation for respiratory alkalosis is by increased renal excretion of bicarbonate. In acute respiratory alkalosis, the bicarbonate concentration level decreases by 2 milliequivalents per liter for each decrease of 10 millimeters of mercury in the PaCO2 level. How do you know the difference between uncompensated, partially and fully compensated? We are going to use respiratory acidosis as an example. The same principle can apply to all the other acid-base disorders. Uncompensated respiratory acidosis. Uncompensated respiratory acidosis occurs when respiratory acidosis is present, with pH acidic, under 7.35, and PaCO2 acidic, over 45 millimeters of mercury, but the metabolic system does not act to correct it, marked by HCO3 in the normal range, 22 to 26 milliequivalents per liter. Partially compensated respiratory acidosis. Partially compensated respiratory acidosis occurs when respiratory acidosis is present, with pH acidic, under 7.35, and PaCO2 acidic, over 45 millimeters of mercury, and the metabolic system acts to correct it, marked by an HCO3 level that's basic, over 26 milliequivalents per liter. The metabolic system's goal with compensation is to get the pH to the normal range. In the case of partially compensated acidosis, the metabolic system has only partially succeeded in correcting the acidosis, because the pH is still acidic and outside the normal range. Fully compensated respiratory acidosis. Fully compensated respiratory acidosis occurs when respiratory acidosis is present, with pH normal but closer to acidic, 7.35 to 7.39, and PaCO2 acidic, over 45 millimeters of mercury, and the metabolic system acts to correct it, marked by an HCO3 level that's basic, over 26 milliequivalents per liter. Again, the metabolic system's goal with compensation is to get the pH to the normal range. In the case of fully compensated acidosis, the metabolic system has succeeded in its goal of correcting the acidosis, because the pH was pushed back into the normal range. George Kent is a 54-year-old widower with a history of chronic obstructive pulmonary disease and was rushed to the emergency department with increasing shortness of breath, pyrexia, and a productive cough with yellow-green sputum. He has difficulty communicating because of his inability to complete a sentence. One of his sons, Jacob, says he has been unwell for 3 days. Upon examination, crackles and wheezes can be heard in the lower lobes. He has tachycardia and a bounding pulse. Measurement of arterial blood gas shows pH 7.3, PaCO2 68 millimeters of mercury, HCO3 28 millimoles per liter, and PaO2 60 millimeters of mercury. How would you interpret this? Correct answer, B. Respiratory acidosis, partially compensated. The patient has respiratory acidosis, raised carbon dioxide, resulting from an acute exacerbation of chronic obstructive pulmonary disease, with partial compensation. Carl, an elementary student, was rushed to the hospital due to vomiting and a decreased level of consciousness. The patient displays slow and deep, co-smell breathing, and he is lethargic and irritable in response to stimulation. He appears to be dehydrated, his eyes are sunken and mucous membranes are dry, and he has a 2-week history of polydipsia, polyuria, and weight loss. Measurement of arterial blood gas shows pH 7.0, PaO2 90 millimeters of mercury, PaCO2 23 millimeters of mercury, and HCO3 12 millimoles per liter. Other results are Na plus 126 millimoles per liter, K plus 5 millimoles per liter, and Cl 95 millimoles per liter. What is your assessment? Correct answer, metabolic acidosis, partially compensated. The student was diagnosed with diabetes mellitus. The results show that he has metabolic acidosis, low HCO3, with respiratory compensation, low CO2. A cigarette vendor was brought to the emergency department of a hospital after she fell into the ground and hurt her left leg. She is noted to be tachycardic and tachypneic. Painkillers were carried out to lessen her pain. Suddenly, she started complaining that she is still in pain and now experiencing muscle cramps, tingling, and paresthesia. Measurement of arterial blood gas reveals pH 7.6, PaO2 plus 120 mm of mercury, PaCO2 31 mm of mercury, and HCO3 25 millimoles per liter. What does this mean? Correct answer, respiratory alkalosis, uncompensated. The primary disorder is acute respiratory alkalosis, low CO2, due to the pain and anxiety causing her to hyperventilate. There has not been time for metabolic compensation. Ricky's grandmother has been suffering from persistent vomiting for 2 days now. She appears to be lethargic and weak and has myalgia. She is noted to have dry mucous membranes and her capillary refill takes greater than 4 seconds. She is diagnosed as having gastroenteritis and dehydration. Measurement of arterial blood gas shows pH 7.5, PaO2 85 mm of mercury, PaCO2 40 mm of mercury, and HCO3 34 millimoles per liter. What acid-base disorder is shown? Correct answer, metabolic alkalosis, uncompensated. The primary disorder is uncompensated metabolic alkalosis, high HCO3. As CO2 is the strongest driver of respiration, it generally will not allow hypoventilation as compensation for metabolic alkalosis. Baby Angela was rushed to the emergency room following her mother's complaint that the infant has been irritable, difficult to breastfeed, and has had diarrhea for the past 3 days. The infant's respiratory rate is elevated and the fontanelles are sunken. The emergency room physician orders ABGs after assessing the ABCs. The results from the ABG results show pH 7.39, PaCO2 27 mm of mercury, and HCO3 19 milliequivalents per liter. What does this mean? Correct answer, metabolic acidosis, fully compensated. Baby Angela has metabolic acidosis due to decreased HCO3 and slightly acidic pH. Her pH value is within the normal range, which made the result fully compensated. Bonus question. Interpret this result of a newborn admitted to the PICU, who was diagnosed with respiratory distress syndrome. Please share your answer in the comments section. pH 7.47. PCO2 51 mm of mercury. PO2 plus 291 mm of mercury. HCO3 37 millimoles per liter. We have come to the end of another fascinating video on arterial blood gas. I hope you have learned something. Please like, share and subscribe. Thank you.